We're going to talk more about that, but now I'd like to invite Kim Noonan to share our last two case studies, Aaron and James. Thank you.
Good afternoon. So we saw that in the last case study, Mary was treated in the upfront setting. So our next two studies, case studies that we're going to talk about are Aaron and James, and they're both in the relapse setting. So here first we have Aaron. He's a married, retired plumber, 68 years old. And he presented the usual way where people have pain, workup maybe with an SPEP, really led to that diagnosis of multiple myeloma. He has normal cytogenetics. What's interesting about Aaron is that he, right from the beginning, was bone marrow, he was ineligible for transplant because of pulmonary hypertension. He also has past medical history of diabetes, as well as the fact that he's an ex-smoker. So he was treated with BRD, much like Mary, and then put on maintenance lenalidomide, as Beth spoke about. And you know what? He did pretty well for a little while, until December of 2018, when he was noted to have a biochemical relapse. And so if you look on your right-hand side, if you look at that, the flow sheet data, right at the very beginning, he had about 5 grams of M protein, and he came down, and we really didn't hear from that disease for a little while. And then he slowly creeped up over 2.5 years. So, you have to work this up. He didn't really have any other symptoms. His lab values were normal. We looked at a low-dose whole-body CAT scan, and there were no new lesions. So that sort of brings us to the question of, was he symptomatic or was he asymptomatic? And we can see, you can read what symptomatic is all about, and we'll talk about that later, but asymptomatic biochemical relapses, you have this rising M protein in the setting of, maybe, no other symptoms. You work it up, you look at SPEPs, and you don't really have anything else to work with. So you sort of say to yourself, we need to, at some point we're going to have to treat this guy. When is that going to happen? And do we do it now, or do we wait until later? Often you might see a little bit of a waxing and waning of M spikes. They can come and they can go, and it kind of can trick you. So the relapse workup is similar to the workup that we did initially when people are first diagnosed, but we're going to look at the serum protein electrophoresis as well as the urine protein electrophoresis. And certainly we're going to follow the CBC to make sure that this patient isn't becoming more anemic, right? And we're going to think about chemistries. What's his renal function looking like? And then look at the kappa lambda light chains and the M protein that we talked about. So we could consider doing a bone marrow. I recently did a bone marrow on a patient that had a little bit of an M spike, and to my surprise, he had 90% cellularity with plasma cells. So they can trick you. These myeloma patients can trick you. You want to also follow this with imaging. If you haven't done a low-dose CAT scan in a while, maybe you want to repeat that. If somebody like Aaron, 2.5 years ago, presented with a little bit of an M spike, you sort of want to follow that over time.
As Dr. Noonan mentioned, there are many different ways that patients will progress. They might look like there's not a lot of protein, but if they're not feeling right, use your nursing gut and tell the provider, or encourage the patient to let their provider know they're just not feeling well. Maybe additional workup is necessary. You've seen these buffet of treatment options, which are listed on the left-hand side. Again, we have these drug classes. It's amazing. And in this day and age, we have the IMiDs, lenalidomide, pomalidomide. Thalidomide's not in there, but I still use a lot of that to treat myeloma. And then they have proteasome inhibitors, bortezomib, carfilzomib, ixazomib. Then you have your monoclonals, Elotuzumab, Daratumumab. And then the other ones, HDAC inhibitor, panobinostats, also FDA approved, cyclophosphamide, bendamustine, doxorubicin, lots of options. So how in the world do you help your patient navigate this? This is what we're going to talk about now. There's a practical approach to treatment that many of us take at our institutions. Again, it's like that Venn diagram with the circles we looked at before. You take your data from the clinical trials, the clinician experience, the patient experience. How did they do with the drug in that same class before? Did they get a horrible rash from an IMiD, or did they get any other neuropathy from another agent? So you take into the patient preference as well as that. So how is their other health factors doing? Did they develop a heart disease, stroke, or other conditions? Do they have to attend a wedding, or do they have family that lives out of town? So again, all of these disease and treatment-related factors are considered. So with these new agents, some patients achieve deeper responses. So the prior two graphs we looked at how patients will ultimately become refractory to treatments as the clones will change over time. Now I'm pleased to report that some people will get their deeper remissions early on after their second or third therapy if we find the right recipe to control the myeloma disease in their body. But you still have an overproduction of a clone. That clone that was able to survive the transplant or the clone that was able to survive the prior 5 lines of therapy can be a very resistant clone. Why? The immune system is meant to protect you from getting sick, and now it's just goofy, dysfunctional, making all these clones. So one of the things that we think about is the way to better use the drugs we have available. This study looked at the doses of dexamethasone and how it improved the event-free survival. 2010, we had a study by Dr. Raj Kumar with lenalidomide and high versus low-dose dexamethasone, and now we have this study with the RD continuous and lower doses of the effective agents. And what it's shown is that less was more in some patients. They had better progression-free survival. Frailty scores are very important in many hematologic and solid tumor malignancies these days, and we have a myeloma frailty score calculator.net you can access. We have some other information in our appendix slides. Basically, you want to calculate how fit the patient is with a score of 0, 1, or greater than 2, and it informs us to the correct doses. So if your patient has a very frail, you might want to do something called RVD light, which is lenalidomide, bortezomib, dexamethasone, but in reduced doses to address that frailty of that patient, to reduce the chance of treatment discontinuation.
All right, so back to Aaron. You know, we heard Joseph talk about shared decision-making, and certainly we want to consider what is important to Aaron as well as his family, as well as his providers. And so also entered into this, he lives close to the clinic, right? So it's not somebody who's going to be coming from, you know, the other side of the country. So that, I think that's extremely helpful. He's progressing on lenalidomide maintenance, and so the question here is when are we going to treat him, not, you know, not if. And he also has peripheral neuropathy. We saw before that he received IV bortezomib, which really has an increased incidence of peripheral neuropathy. So Aaron and the healthcare team decide that they prefer a combination, that really is, he's going to achieve a better outcome with that. So with that, we sort of think about pomalidomide. Pomalidomide is an IMiD that, in people that are refractory to lenalidomide, this is really a very good choice. It's an oral IMiD, and it's important to monitor counts when people are on pomalidomide. Neutropenia is the most common grade 3, 4 AE, and other common side effects include GI toxicities, constipation, diarrhea, VTEs too, so you really want to think about prophylaxis with anticoagulant, and fatigue with this group. And so you want to think about how we're going to manage these side effects. Certainly, we want to manage the individual side effect, but we want to consider perhaps lowering the dose of pomalidomide because people are going to tolerate it better. That really is what we're after, you know, sort of what is the best treatment for you and what is the best quality of life that we can offer you while you're on this treatment. So, so we decide that that's, you know, what we're going to treat him with, but what are we going to put it with? Because we decided that combination therapy would give Aaron the best outcome. So would we treat him with a monoclonal antibody? And perhaps we would. And so we have 2 options with monoclonal antibodies. One is Elotuzumab, and the other one is Daratumumab. And so I don't think you can have dessert until you can say Elotuzumab and Daratumumab 15 times without messing up. And if I do it, then even better, right? So anyway, Elotuzumab targets SLAMF7. Anybody here say, what the heck is a SLAMF7? It's a signaling lymphocyte activation molecule family, and specifically, this is that protein 7. So about 10% of everybody that receives Elotuzumab or ELO is going to experience an infusion-related side effect despite really giving pre-meds, and similar to most monoclonal antibodies, we're going to pre-treat people with dexamethasone. We give dexamethasone 3 hours to 24 hours before we infuse Elotuzumab, and believe me, we really hold that standard. We have patients that forget to take their dexamethasone, and now it's, you know, 10 o'clock, and I know they're not going to treat them until 1. So we're pretty serious about the pre-treatment with dexamethasone before we give Elotuzumab. The way that it's given weekly for 8 weeks, and then it's given every other week. So you want to monitor and make sure you look at blood counts, and you're going to hold it if it's low. You're going to think about VTE prophylaxis when people are on pomalidomide, as well as if this drug is going to be used with lenalidomide. You also want to monitor dexamethasone, you want to monitor glucose, because we know that Aaron is a diabetic. So you want to make sure that he's doing okay with that. Renal, hepatic, paying attention to the renal and hepatic status is very important. And you want to assess for response, which I think we're going to talk about more in the next slide.
Absolutely, and as Kim mentioned, that 3-hour window, especially when they're starting treatment, is important. Oftentimes, if I trust my patient, which I try to trust everybody, right? But there's some people that just can't sit in a chair while the pre-med works, so we have them take it at home 3 hours ahead of time. And eventually, if they've taken the Elotuzumab for a while, they can just start taking it without actually the steroids over time. But this study highlights on here, this was a phase 2 study with Elotuzumab, pomalidomide, and dexamethasone, EPD. This was a phase 2 study. Everybody got the treatment, and what it showed is that patients had a very good remission status when they had the drugs combined together. The thing about the Elotuzumab in this study is that they went weekly for 8 weeks and then monthly, which is different from Elo combined with lenalidomide dex, which is every other week forever, pretty much. So it's important to know the different dose schedule and why your patient's getting what. There are special considerations with antibody therapy. As Kim mentioned before, we worry about a lot of different interferences. There is a potential interference with lab tests. So this myeloma is an abnormal clone, and oftentimes it's IgG kappa or IgG lambda. And if you have a spike in the blood, it might just be the Elotuzumab or Daratumumab, which we'll be speaking about in a moment. And so it's important to reassure patients who are looking at their lab tests and assessing for response and say, oh, I didn't get rid of this M spike in my blood. It might actually just be the medication. New laboratory assays are in development but are not ready for prime time yet in most labs. Daratumumab is a monoclonal antibody directed to CD38. CD38 is loosely linked to red blood cells, but it's also a cell surface marker for myeloma cells. And through the 4 mechanisms of immunomodulatory effectiveness, like antibody-dependent cellular mediated toxicity, et cetera, you block that CD38, and then the myeloma cells die.
A little bit more
Hopefully, they die.
Right. A little bit more about Daratumumab. So as you can see, that it was initially approved with 3 prior therapies back in 2015, and that was for monotherapy. And then it sort of moved up for two prior therapies in 2017 with pomalidomide and dexamethasone. And I think it was, in 2016, it was 1 prior with lenalidomide and dex, as well as with bortezomib and dexamethasone. And I think it's very exciting that last year, VMP plus Dara was approved for first-line, non-eligible FDA, non-eligible transplant patients. So it's really moving. I think really the message here is keep looking out, because we're going to be using Daratumumab in a lot of different ways, and probably more often in the upfront setting. So a couple of things to consider with Daratumumab. So the patient is sort of going to come in, and that first day, that infusion is going to be lengthy for them. And so to say to them, today it's going to be lengthy, maybe 8 hours, maybe 10 hours if there's an infusion-related reaction, which about 45% have during their first infusion only. But over time, we're going to be able to increase the time that we're able to give Daratumumab. We pre-med people, as we do with most monoclonal antibodies, with corticosteroids, antipyretics, antihistamines, and patients are asked to take steroids for either 1 or 2 days, depending upon the steroid that we use. Often, we're able to get rid of the steroids after the first cycle of Daratumumab. The herpes prophylaxis is very important, too, with people that are receiving Daratumumab.
And I think we also mentioned the interference before and the type and cross-match issues. Again, the CD38 is loosely on the red blood cells, so if your patient is at risk for needing a blood cell transfusion, you need to get a baseline type and screen and then follow that up and alert the blood bank. So you should have your standard of care in your institution. Find out what that is if you have patients that are receiving Daratumumab. These are 2 studies highlighted on this slide. Again, we see all these mixing and matching of classes of drugs, the IMiDs, the proteasome inhibitors, monoclonals, and the cool thing about that is that you can get various response rates and you can monitor for the side effects. So to the left, you have the CASTOR clinical trial, and that was combining DVD, Daratumumab dex, versus bortezomib dex. And you can see in this study, we had a longer progression-free survival. People stayed in remission with the 3 drugs more so than the 2 drugs, bortezomib dex. So the next study is the POLLUX clinical trial, which is the lenalidomide dex versus Lendex. And then you can see the better progression-free survival, the benefit at 24 months of those that had the 3 versus the 2 drugs. Now, because we love acronyms in myeloma, we have another regimen, Daratumumab dexamethasone. We heard about the clinical pearls from Kim when she was talking about pomalidomide. It's an oral agent that's used, an imminent agent, and we saw in this study that there was an improved progression-free survival in people that had more than 2 therapies. They still went into a good remission. Remember, we talked about response and remission, that partial response is 50%, then the VGPR is a 90% reduction in proteins. That's what this slide is showing here. So you get pretty deep remissions even if people have been on prior therapies, which is excellent news. These 2 ways of giving daratumumab are currently under investigation. The one to the left shows a 90-minute infusion of daratumumab via rapid infusion, and this is great for our patients. After the first 2 infusions, if they haven't had a very serious infusion reaction, we can speed it up to 90 minutes, and that's our standard of care at our clinic and Cleveland Clinic in Ohio, as well as the Dana-Farber and many other institutions. It's been shown to be safe and effective. Remember, when drugs are studied, we want to find if they're effective. Then later on, we find better ways of infusing or administering them, and that's why now, after the 2015 approval, we're learning that it is safe. Subcutaneous daratumumab continues to be in clinical investigation. It's not commercially available. Many centers around the country are studying it for myeloma and other plasma cell-related disorders, and there seem to be no new safety signals, so hopefully subcutaneous will be available in the future. Here's a phase 3 study of the DRD versus RD, Dara, lenalidomide, and dexamethasone versus 2 pills, LD, lenalidomide, dex. So what do you think I'm going to say about this study? Better progression-free survival of the 3 drugs versus the 2 drugs, right? So patients 71% versus 56% in remission, a 44% reduction in the risk of progression or death. And these are newly diagnosed patients. So as Dr. Noonan mentioned, we're going to be moving this earlier on in the treatment paradigm, this daratumumab agent, in many cases.
All right, so we'll go back to Aaron. And so after 3 months on daratumumab, pomalidomide, and dexamethasone, he is tolerating therapy very well. His glucose is under very good control, as his calcium, creatinine are all really very well under good control as well. And so we hope that he can stay on this therapy for at least another, 20, 30 years, right? That's our goal. That's absolutely our goal. So as we've been talking about, it's really important to look and update the survivorship care plan. He really needs to know what tests we're following. Is it, his free light chains? Is it the M protein? What are we following? And what current doses of therapy is he on? Pomalidomide, did we have to lower that a little bit? And then to review, to talk about what the PCP is going to handle, the well baby care, who's going to do the PSA, are we going to manage the vaccinations back where we are? So it's really, I think, important to set up ownership of that. And again, with health promotion, that Sandra wasn't going to spend too much time talking about. Diet, exercise,
Which
lifestyle.
keeps coming back.
Don't smoke, and really don't drink too much. Support groups are essential, and for somebody like Aaron. So we're going to wrap Aaron up, and we're going to move to James. And James is a 63-year-old who is a widowed store manager, helps with his 2 daughters financially, diagnosed in 2013. And he, like the other 2, was treated with BRD, but a little bit different. He did receive a stem cell transplant, and that was followed by 2 years of lenalidomide. And so he did well until 2018 when he presented with leg pain. A skeletal survey reported new femur lesions as well as rib lesions. And so we see that, when we're thinking about what kinds of treatment options we have for James, and by the way, he has plenty of treatment options, I was becoming exhausted when that litany of options was discussed by Beth. I mean, there's so many options.
Me too.
For James, right? She was almost, I was out of breath for Beth. And so you need to, the fact that he doesn't have a cardiac history, the fact that he lives near the clinic, these are all going to enter into the shared decision-making. And so the two options that were discussed is maybe IRD and KRD, which we're going to talk about in the next few slides. But we also have to think about the fact that James is symptomatic, right? So look at those symptoms. He is somebody that came in with worsening pain. He has an increase in his creatinine. He also had an increase in calcium. So we're really stuck. We really have to treat James. All right, and so one choice that we talked about would be IRD, which is an all-oral regimen, Activism, lenalidomide, and dexamethasone. I'll repeat that again because I think there was a question on this, right? It might have been, I don't know, but it's an
Leading the witness, Kim.
It's an all-oral regimen, right? And it was approved in 2015, and so it's approved for patients who have received one prior therapy. Activism is administered weekly, days 1, 8, and 15 on a 28-day schedule. It's taken on an empty stomach 1 hour before and 2 hours before or 2 hours after food. And so some of the things you need to think about, and we've been talking about this, is really oral adherence, right, to their medication, but also cyclical sort of thrombocytopenia. People can develop peripheral neuropathy on ixazomib. Peripheral edema, nausea, too, is common for patients that receive ixazomib.
And this is an example of a calendar. So many nurses are charged with helping patients adhere to their treatment, and calendars and reminders, electronic reminders, are some of the most important things. Remember, we said Activism is just 3 pills a month. So I take an orange highlighter, just like this slide, and I do orange, orange, orange. I ask the patients what day of the week you want to start, and we fill that in. Then the lenalidomide tends to be 25 milligrams starting dose. Remember, we dose reduce Activism for hepatic or kidney disease to 3 milligrams if severe. Lenalidomide dose reduce for kidney disease. And then dexamethasone we can dose reduce for frailty, 20 to 40 milligrams weekly. So find out what the correct regimen is and help your patients learn how to make their own calendars so that they can adhere to treatment better, and then they don't have to keep calling you and you don't have to keep making the calendars yourself. They're really taking ownership of their illness. We talked about the IRD, Activism, lenalidomide, and dex. This was a study of 722 patients that was reported a couple years ago. It was an international study which showed that there was a progression-free survival in patients who had at least one therapy or more of 20.6 months when they took the 3 drugs, IRD, pills, you take it home, versus placebo. Again, there's monitoring. There's baby aspirin for the lenalidomide. There's shingles prevention with the Activism, but it is something that can really work for their lifestyle in many cases. Kim?
Okay, and so another option for James would be carfilzomib, lenalidomide, and dexamethasone. And so carfilzomib, as you can see on the right-hand side, has many doses, right? So we give carfilzomib 20 milligrams per meter squared for the first cycle, and then we increase the dose, and whether that's going to be 27, 56, or 70, which is the weekly dosing of carfilzomib, is really up to really how the patient's tolerating it, as well as the goals of therapy. And so, for some of the clinical pearls that we need to think about with carfilzomib is that the patients should be hydrated when they receive carfilzomib, but not overhydrated. You really need a good understanding of the patient's cardiac and pulmonary status, and you need to optimize their cardiac issues with diuretics, for example, as well as maybe inhalers for pulmonary issues. Aspirin should be used for thrombosis prophylaxis, as well as herpes prophylaxis should be used. You need to monitor count, and I think that infection control and infection reporting is extremely important with this, because people really can become very infected quickly, and we really need to, people have great outcomes if it's reported and we act on it quickly. But think about, thrombocytopenia is often seen in people that are receiving carfilzomib, anemia as well, and fatigue. Really, I think overwhelming fatigue is what I often hear patients describe. However, this drug in combination with other agents is an excellent choice for somebody like James as well.
And it's important if your patient is telling you, and you're an infusion nurse, or you're in the inpatient, encourage your patient to speak up to the provider, because we can provide dose reductions and modifications for fatigue, for thrombocytopenia, and we can take planned treatment holidays in many cases to improve their quality of life. Drugs don't work if people don't take them. I didn't say that C. Everett Koop did, but we want to try to keep our patients on therapy, because as I've demonstrated through these case studies, staying on therapy is better than stopping therapy no matter what you're on. This particular study investigated 2 different dose levels of carfilzomib, once weekly 70 milligrams per meter squared IV versus twice weekly 27 milligrams per meter squared. In myeloma, for all doses, we do a ramp up starting at 20, so don't forget to tell your patients, because they'll think it's not working. If you increase the dose the next week, they'll call you from the infusion center. But in terms of the response rate, these patients did not have any significant increase in toxicity, but they responded better at that higher weekly dose, which goes against what we used to be doing in terms of the carfilzomib.
Okay, and so back to James, and when you look at the fact that IRD was selected, was there ever a doubt that he wasn't going to choose the all-oral regimen, right? Considering, having to come to the clinic on a pretty regular basis. So he selected IRD in combination with his providers. And after 4 cycles, he achieved a VGPR, and he's tolerating treatment well, and he likes his all-oral regimen and the convenience of not having to come to the clinic that often.
There are many other drugs or regimens in development, and I'm pleased to show you that there are immuno-oncology approaches, which we'll talk about in a moment, other approved drugs for other indications, such as venetoclax, an oral drug approved for CLL, as well as ibrutinib, which has been studied, and then selinexor. Again, we're investigating better combinations, sequencing of drugs as well. I'd like to highlight for a moment selinexor. This is a very unique drug. It's a selective first-in-class oral inhibitor of nuclear export, or SINE compound. So we have the MIBs, the MABs, the MIDs, and now we're going to have the SINEs. Just kind of made that up, but it's actually been to the orphan drug designation for FDA and fast track designation by FDA. How does this work? Well, the selinexor is a covalent oral selective inhibitor of this XPO1 protein. It blocks the tumor suppressor genes from being exported from the nucleus. We need the tumor suppressor genes there so they can kill the myeloma cells. So it blocks it from leaving the nucleus so you can kill more cells. The selinexor had a STORM clinical trial. There was a 26.2% overall response rate. We know that when patients fail bortezomib or pomalidomide or IMiDs, they confer a poor prognosis, short survival. So this is a newer class of drugs that can potentially give them a 26.2% response rate. Most of the patients had 7 prior treatments, and many of them were refractory, what we call pentarefractory, where nothing else was working with them. We had stringent CRs seen in this study, as well as a median overall survival of about 8.6 months. The important thing for you to remember as a nurse who's hearing about selinexor for the first time is that when it comes to market, you're going to be critical to helping with side effect management. This drug is effective, but there can be some side effects such as fatigue, thrombocytopenia, weight loss, and other things which can be very effectively managed by nurses if we work with our patients. There are no significant major organ toxicities in prior clinical studies or bleeding or infection rates, but it's still something that needs to be monitored. We have new ways to target and kill therapy, CAR T-cell therapy. You know about that from lymphoma. We'll talk about that in a moment. BiTE antibodies, bispecific T-cells engagers. We're engaging the T-cells to fight the myeloma cells. And then finally, drug antibody conjugates. So such an exciting time of myeloma in 2019. Briefly, I want to share the CAR T-cell clinical trial in myeloma. I'm very excited to report that, remember, we get some of our deepest remissions after prior therapies. The BB2121 is a second-generation CAR T-cell therapy. It targets the CD269, and it's a phase 1 clinical trial. And of these 43 patients, many with prior therapies, you still had deep and durable responses. And they get the cellular therapy, and then you just observe them. And so its very active dose had a median progression-free survival of 11.8 months, again in a group of patients that had a lot of prior therapies. Kim?
Okay, and so in finishing up, before we get to the questions, right? So as you can see from today's discussion, there are so many options for multiple myeloma patients, especially over the last decade. There's just so many to consider. But what we do need to consider is how we're going to educate ourselves, our patients, about when we're going to use these, how we're going to use these, look at the different schedules that we're using these drugs on. So nursing is absolutely the key to all of this. And so patients rely on your guidance and your expertise in providing the quality care that they deserve.
So let's do the last few questions. I know you know all the answers, right? Which of the following is used for the diagnosis of myeloma-related organ dysfunction? Fish, MGUS, salt, or crab? I hope you didn't misplace your ARS. I love to see the post-test, and we'll show you what your responses were when they stopped the music. 80.3%, great, much better. Next one. Which element is essential to foster shared decision-making? Greet your patient, seek your patient's participation, sharing information by both parties, or building consensus about preferred treatment by both parties.
100% here. We're going to get 100% here.
So, it's so confusing though. For me, and I just listened to the lecture. This is confusing. Let's see how you did. Building consensus. Wasn't it number 2, Joseph? Yeah, seek your patient participation. After all that, they forgot. Remember, the most important thing, seek your patient participation. Invite them to participate. Seek their participation. But you know what? That's why I said it was confusing. I would have picked 4, too.
I would have gotten that wrong. Yeah.
Come back next. Which of the following is true about newly diagnosed patients with myeloma? All should be tested for MRD as soon as possible. Shared decision-making is only effective if the doctor and patient discuss. All patients need to be educated on many topics, including bone, renal, health, and infection, and bone strengthening agents are only recommended for bone damage. Why do these seem harder this year? Who wrote these? We did, by the way. The correct answer is 3. Yay!
Excellent.
Oh, that's awesome. Good for you guys. And then finally, which of the following is an all-oral regimen for relapsed myeloma? KRD, IRD, EPD, or DPD? And the correct answer is, yay, IRD. You all did an amazing job, and thank you so much for sharing our stories of our patients. We'll be here for question and answer.